With that, I would like to introduce Mandi Pratt-Chapman, who is the Associate Center Director and Patient-Centered Initiatives and Health Equity for the George Washington University Cancer Institute. Her research focuses on patient navigation, cancer survivorship, and health equity for the LGBTQI communities. Thank you. Please join us.
Good morning. So I wasn't sure if I should make this opening statement or not, but I decided to when the brochure issue came up. So my pronouns are she and her. Usually I have a slide that says my pronouns. I know we're not here for that today. We're not talking about gender identity, but I do think if we're going to talk about brochures, that talking about who's on brochures and posters that are resonant with the populations we're serving, whether they're sexual and gender minorities, immigrant populations, racial and ethnic minorities, is important in addition to the literacy level. So I'll just make that little shout out. So I don't have any disclosures today. Question for consideration. So I'm going to pose this question for you to consider while I am speaking. I've been thinking about this for about a decade and feel like I've had a little bit of a breakthrough that I'm going to share with you today, and look forward to your feedback and poking holes in whatever you'd like to make it stronger. So my question is, how do we create collaborative healthcare systems with informed patients sharing in decision-making through sustainable patient navigation support? So one of my assumptions, I'm focusing primarily on patient navigation because it has been mentioned repeatedly as a strategy for health literacy. So I will be talking a little bit about health literacy, but mostly about navigation, assuming that that connect is somewhat clear. And I'm going to offer that we need candid conversations about who is doing the work and who is financially benefiting in order to get to the root of this question. So overall, today, I'm going to talk a little bit about the importance of navigator fit, navigator actions that can support health literacy, and potential solutions. I'm giving a good chunk of my talk to sustainable solutions that I'm hoping that you all will have some opinions on. So we've heard a lot about health literacy and the importance of health literacy. About 90 million Americans have trouble understanding and using their health information. And as Irma Mila stated, health literacy is linked to lower use of preventive care, less adherence to treatment, more hospital stays, and poor health status and higher mortality rates. So I'm hoping that I'm already speaking to the payer and hospital audiences that might be in value-based systems. All of these things point to cost, right? So what does a navigator have to do with health literacy? I thought I would, Michael encouraged me to spell this out a little more clearly, so I took a few slides to do this. Navigators can help assess health literacy to make sure information is responsive and concordant with what patients need, help coordinate appointments and provide reminder calls, assess and address barriers to accessing and completing care, providing information on what to expect. I think this is a critical role, what to expect, how the health system works, and what team member roles are, who does what. And then promoting healthy behaviors and connecting patients to appropriate resources. So I stole this from Irma Mila's slides because I liked the graphic, and I kind of replaced all of the bullets with navigator-specific health literacy actions. Again, I'm not going to read this, but ranging from promotion of health behaviors prior to diagnosis to screening guidelines. Again, how does the health system work? How does the specific organization work? What are screening guidelines? How does that patient fit in terms of risk profile? Checking for understanding, checking with the patient, what did you understand? Explaining different team member roles, supporting adherence, supporting advocating for the patient, and supporting the patient's self-advocacy, and emphasizing the importance of follow-up. Lisa's talk yesterday, she talked about 53% of Medicaid patients diagnosed with cancer in DC are not getting treated. I just found out that like 4 weeks ago, embedded in an RFA from DC Health, healthcare finance, that was not widely circulated. And I shared that with her, and now we're working on that together. But that's astounding to me. And maybe that's naive, but that's astounding to me. And also, we heard yesterday about the importance of palliative care, educating about the importance and the difference between palliative and hospice care. All of these things can be done by a non-clinical person, but there's also roles for a diverse range of navigators. So these, again, to kind of reiterate, navigators can help with whether patients can access, understand, appraise, and apply information, right? These are some of our goals. If you're health literate, you should be able to do these things. Access information, understand it, appraise it, and apply it. And navigators can help support that for patients. So this is where I talk about the range of navigation, right? So you want to have a navigator that fits the problem you're trying to solve. Nothing drives me more crazy than listening to how navigators are ineffective and how survivorship care plans are ineffective without describing who is doing what is being covered, what problem they're trying to solve, right? What is the context behind the intervention that is not effective or effective? You can't just throw someone into a system, call them something, and expect it to be effective, right? So for health promotion, I would advocate that often community health workers are the best fit. For challenges that are not symptom management, that are not clinical education, navigators can play a crucial role. Social work is sorely understaffed. It's an underappreciated field. If I could do anything, I would increase the number of social workers in the world and funding for them. And then symptom management, nurse navigation, and nurse symptom management, right? So the type of navigator and the scope of practice has to address what the patient needs are. Who are your patients? What are their demographics? What are the primary needs that they are experiencing? What the specific organizational and community context that you're operating in? And so what are some communication strategies for navigators to get there? These are just a few strategies, not comprehensive, but obviously using plain language. One of my favorite former staff used to say, I don't speak doctor, right? So using plain language, using specific examples, really making things tangible. Using teach back. What are you going to tell your spouse when you get home about what you learned today? What are you going to tell your friend? And then the Ask Me 3, how would you describe your main problem? What do you need to do and why is it important, right? Like really breaking it down. So the rest of my talk, I'm going to talk about sustainability because this is something I've really been grappling with for really the past decade and trying to think, okay, well, God, if I had a PhD in economics, I could solve this, or how do we do this? So I'm going to offer 4 potential sustainability solutions, and they're not necessarily mutually exclusive. The first one is documenting value. So I've tried to advocate and argue that navigation improves health literacy, so I'm going to take that for now as a given. Navigation in the literature has been shown to increase uptake of cancer screenings, timeliness of diagnosis and treatment, patient adherence and completion, patient satisfaction, retention of patients, patient volume, clinical outcomes, care coordination, and reducing no-shows and acute care episodes. So what this can mean within certain organizational contexts is cost savings and ROI. That does not mean it's true for every organizational context, but if you're a hospital system, you're very expensive, right? So keeping people out of the ER, keeping people out of, one thing I learned a few weeks ago, I was in New York at a Komen event, one of the payers had a lecture, and he said, the ER visits aren't even the issue. The issue is admission, because as soon as they get to the ER, a disproportionate number of people are then admitted, right? So ER visits, ICU visits, unexpected admissions, these are huge costs that if you're in a value-based setting, you can seriously show cost savings. So, but I'm going to argue, and this is a paper that actually is in press right now with JOP, and it was a paper that came out of a navigation workshop held by the National Academies a couple of years ago. We talk about the business case of navigation, and you can make that case both within value-based and fee-for-service environments. So within a value-based health system, the University of Alabama had a large CMMI grant to basically launch navigation that was not nurse navigation. It was patient navigators across a wide network of states. And they focused on high-risk, elderly, comorbid patients and found that navigation saved over $780 per patient through reduced acute episodes. In a fee-for-service environment, the University of Pennsylvania found that navigated patients were 10% more likely to stay in their system and use multiple modalities of treatment. So that's revenue in the door, right? And these are just 2 examples. There's a number of examples in the paper that will be coming out. So another question, when should navigation be introduced? So also in this paper, we talk about one case that shows that 35% fewer patients were lost to the system if they were navigated from the point of screening. So once a patient finds out they have a suspicious finding, I think this is key for the issue that Lisa and I are grappling with. If you find out you're diagnosed and then you don't follow up, you need someone there from the time that you have something going on, right? Like, what does that mean? Does that mean it's a death sentence? Does that mean you have to, you need to make an appointment next week, that you need to make it within the year? You need someone really talking to you from that point of adverse finding. So how do you show your value? And this is just a diagram that I put together based on kind of informed by implementation science, right? Like, what is your institutional context and organizational context? What are your patient needs? What are the pain points for providers? If you're not looking at those things, you're not tailoring your intervention to what's going on in your system. Select your navigation model based on context, pain points, patient needs. And then select metrics of importance. So who is making the decision about navigation sustainability? Who's going to decide whether there is a cost savings or it's worth it? And then create your evaluation plan based on those metrics, right? So that's kind of my first show your value approach. Second one is upfront payment. So we know that the oncology care model has introduced and piloted this concept of $160 per patient per month. And my understanding, I'm not an expert on the OCM, but my understanding, and you can correct me if I'm inaccurate, was that many practices were able to show cost savings the first year. The second year was a little bit more challenging, right? Because of the way that you're trying to compete against yourself, right? So my question is $160 the right amount? Should this be revisited on an annual basis or on a periodic basis? But this is a viable way if you provide sufficient funding, an adequate amount of infrastructure support up front, and then expect quality care that includes navigation. I think that that's a potentially viable model. Third model, team-based reimbursement. So there's a couple of things legislatively that are pending, but one of the things that I have been grappling with the last couple of years is that I really don't want to make navigation a reimbursable service in the fee-for-service kind of structure. I don't really want to add another bill to patients, another bill for billing centers to have to deal with. But if we required quality care and required navigation as a component and build for team-based care, I think that is a viable solution, right? Like, what are we expecting for that payment? And navigation should be part of that. So this is where I'm kind of really excited and interested in your feedback. The idea of the wrong pocket problem. So this is my fourth potential sustainability approach. So what we know is that sometimes interventions happen in settings where the value is enjoyed at another level, right? So in DC, for example, some of our federally qualified health centers have added navigators to their clinics. That has resulted in more guideline adherence screening that drives patient volumes to screening centers and to hospitals. So the screening and imaging centers are getting revenue. The treatment centers are getting revenue. But the federally qualified health center doesn't have any way to make back that salary, right? So that intervention is happening in a location that is not garnering the financial benefits necessarily of that intervention. So what do we do about it? One thing is to think about our triple aim, right? We talk about cost and quality a lot, patient and population level quality. We sometimes forget the purpose of healthcare is access, right? Like, sometimes we're missing the access piece. In addition, I actually co-wrote a paper on the missing component of social value in our economic analyses, right? Like, what are we trying to accomplish? Are we accomplishing what we were designed to do? So thinking about what's the value in terms of the access piece. And so our current system is kind of set up, I win, you lose, right? We're in competition, we're business, everything is proprietary, nothing's transparent. So I'm going to suggest, and I'm stealing this from Len Nichols at George Mason, who stole it from an economist in the 80s, so not original to me, that flexible budgeting could be a solution. So if we turn from I win, you lose to I win, you win, and we're looking at a synergy that is greater than the sum of the parts, we can potentially have a value that's greater than just I win this piece, you win that piece. And this is how the proposed system works. This image is taken from a recent webinar that Len gave on a collaborative approach to public good investments. And the idea is that anyone who has a stake in the value of a problem, like solving a particular problem, can somehow quantify what that value is and state it to a neutral, third-party, trusted broker. You don't have to tell your competitor. You don't have to tell the person down the street. But you have some idea of what this means to you. And it may be in economic terms. It may be mission-oriented. But everybody has some sense of what the value of solving this problem would be. And so I'm laying out this example for you to consider. So I thought about, I'm thinking about DC, right? What might it cost for DC or a city to really provide adequate navigation services and social support services to cancer patients? This is hypothetical. This is not based on data. So I threw some numbers out there just to kind of create this straw man for you to react to. So let's say for Medicaid, the value of providing patient navigation to solve the earlier stage diagnosis, right? You're not diagnosing and then someone's not coming back for 2 years and they end up in the emergency room and then in the hospital with advanced cancer. Let's say the value of that is $5 million because there's a large number, there's 53% of the patients that are currently not following up immediately. And for Medicare, let's say it's 3.5, et cetera, you get the idea. So let's say the total value of the solution is $14 million. Let's say the cost of the solution is $10 million, right? So the only way this economic model works is if the cost of the solution is less than the sum value for the stakeholders. So it doesn't work for everything, right? And so the way that this works is you create this simple cost share. So who are the stakeholders? You divide your cost by the number of stakeholders, and then you assess based on the value a tax, right? Which may be subtracting that simple cost or a component of that simple cost, or adding based on your potential ROI or your potential value that you can get from that innovation. And then you end up with this kind of net price that should actually total, 10 million, so that's a typo on my part. But basically, you end up with a 28% return on investment for all stakeholders. If they weren't talking to each other and they didn't trust this trusted broker, they would end up with nothing, right? So everyone benefits, and it costs less than what the value is to everyone, right? This is the idea behind it. So that's what I put out for you to consider, and what I will, I'm going to try to be working with Lisa on to try to think about how might that work in DC. And I just wanted to leave you, I'm doing a qualitative study right now with a student, and I'm precepting, and she is interviewing navigators, administrators, and clinicians in, I want to say 9 systems across the country. And one of the respondents said, we wanted to quantify what we were doing. How do we figure out return on investment for navigation? And what they found was it was actually the most profitable program they've ever had in their health system. So again, if you tailor to context, you look at your pain points, you look at your organizational needs, you look at your patient needs, find the right navigator fit, and identify those value metrics, I think that we can come up with a sustainable solution. A couple of resources. This is a training that my team put together and we piloted for the last couple of years. It's a health equity system level training. We include health literacy in part of the training, and it's a hybrid training, so the online component is freely available to you. You can access it through our online academy, and Team Care is the code. You can just put that in. You get 5 free CME. But there's a discussion of health equity. There's a discussion of health literacy. There are spotlights on African American, Latino, and LGBT inequities, and then interpersonal and system level strategies for equity. And this was just a statement from one of the participants that the course made them think about what actions an organization needs to take to really be patient-centered. And then the ARC Health Literacy Universal Precautions Toolkit, wanted to provide you with a resource there. And that's all I have for you. So I look forward to your questions.